Hi, my name is Madison Sheets. I'm a pharmacy student at the University of Texas at Tyler, and today my in-service presentation is over a drug called Tolvaptan. Title of my presentation is It Worth the Salt? Some objectives for today include highlighting the different forms of Tolvaptan in clinical settings, to discuss the role of Tolvaptan in hyponatremic patients, to point out significant studies that can confirm or discourage its use, and then also to consider whether Tolvaptan should be considered for a hospital formulary. Okay, so some background on this drug. It comes in two brand names. Genarc is the first one, and the second is Samska. So Genarc is specifically indicated for autosomal dominant polycystic kidney disease. It has a black box warning for hepatotoxicity. It is restricted through a REMS program, so that's important to note, and it comes only in 60 milligram tablets. Samska, on the other hand, is exclusively used for hyponatremic patients. It comes in 15 milligram tablets and 30 milligram tablets. It's indicated specifically for SIADH and heart failure patients, and its significant adverse effect is excessive thirst. There isn't any restrictions as far as a REMS program or black box warning with this one because it does have less of that Tolvaptan drug in it. Is not in that 60 milligram tablet form like Genarc is. So into specific indications, as I said, it is specifically indicated, Samska is specifically indicated for SIADH. This is the one that we're going to focus on today just because this is the formulation that you see most often in hospitals and in hospital settings. This is used for hyponatremic patients, so this is the most important indication that we can talk about today. So 3 bullet points here, as you see in the slides, is for euvolemic and hypervolemic hyponatremia, which is indicated as less than 125 milliequivalents of sodium in the serum, or less marked but symptomatic hyponatremia. Also for patients who have resisted correction with fluid restriction, and then this also includes patients with heart failure and SIADH specifically. It is not used for anyone with underlying liver disease, severe kidney disease, anuria, hypovolemic hyponatremia, polycystic kidney disease or ADPKD, as Genarc is specifically used for, and CYP3A inhibitors. So a little bit about the mechanism of action of Tolvaptan. It is an orally active selective V2 receptor antagonist. It blocks that vasopressin and the ADH. This aquaretic activity in the distal nephron includes the excretion of electrolyte-free water without changing the overall total level of electrolyte excretion. So it retains that sodium in the body while excreting water. This in turn keeps sodium in the body and excretes water that is being retained. So just as a transition, question 1, Samska is restricted through a REMS program, true or false? That is false. That is the other brand name for Tolvaptan, that's Genarc. It is restricted through the REMS program due to its higher content of Tolvaptan per dose. So a little bit about SIADH. According to the DiPiro pharmacotherapy textbook, patients diagnosed with SIADH should be treated preferentially with 3% normal saline. And when these patients have a urine osmolarity of over 300 milliosmoles per kg, an IV loop diuretic is normally added to that regimen, such as furosemide or bumetanide. And dosings are also on the slide for those two. As another transition, there are 2 significant studies that are normally brought up when referring to this drug to any kind of physician or any kind of clinical setting. These 2 were conducted a few years ago. One of the most notable is the SALT-1 and SALT-2 trials. These happened over a long period of time. What happened was there was a group these were both prospective studies. There was a group of patients who were given Tolvaptan and a group of patients who were given placebo. They were watched over a 30-day period, and the patients who were given Tolvaptan, it raised their serum sodium levels around 7 milliequivalents, and opposed to the 2.5 milliequivalent rays of serum sodium in the placebo patients. So the notable thing about this study is those numbers, along with the fact that sodium levels did decrease greatly in the observed 7 days prior or after discontinuing the drug in the patients. So they received it for 30 days, and then they were also watched for that week after that 30-day period, and their serum sodium levels dropped significantly. So that's something to note for later. There was another study, it's called the Everest Outcome Trials. This specifically analyzed the effects of tolvaptan in acute decompensated heart failure with signs and symptoms of volume overload. So there was also 2 treatment groups. There was the patients who received tolvaptan and the patients who received a placebo. In the tolvaptan treated patients, their serum sodium did increase an average of 5.5 milliequivalents, as opposed to the placebo patients whose sodium increased about 1.9 to 2 milliequivalents. The results, as quoted from the study, say that tolvaptan initiated for acute treatment of patients hospitalized with heart failure had no effect on long-term or heart failure-related morbidity or mortality. This is important because one of the indications of this drug, as noted beforehand, was that for heart failure, and so this study is kind of debunking that in a clinical trial setting. So question 2, which is our next transition, which trial is most referenced for indication of tolvaptan in heart failure? We just talked about this. It is the Everest trial. Results were inconclusive though. There was that noted increase in serum sodium, which is important, but as far as heart failure, that increase in or that effect on long-term morbidity and mortality was not seen. So some things to consider. It is an effective drug for raising sodium levels. This has been clinically proven. Its side effect profile is not super high risk as opposed to generic, but by no means is this a benign drug. We shouldn't ignore that. Its effects are short-term. Outpatient use is not encouraged. And the cost is what deters its use in many institutional settings. So these are just some noted facts about this drug. This is our next transition into cost versus benefit. Notably, there are some things that are given prior to tolvaptan for hyponatremic patients. Sodium chloride, as noted in the DePiro textbook, is normally given. Some costs that I've pulled from a hospital with a McKesson wholesaler is that 1 gram tabs of sodium chloride, 3%, is about 6 cents. For a 500 milliliter bag of 3% NS is about $2.12. And a 500 milliliter bag of NS that's 0.9 is about $1.31. So if you are also paired with that serum osmolality level, as I mentioned earlier, loop diuretics are sometimes added to that regimen. It's about 4 cents for a 40 mg tab of Lasix. It's about 63 cents for 20 milligrams IV of Lasix, and 67 cents for a 40 milligrams IV of Lasix. Demeclocycline is another drug that has been given in the past for SIADH or hyponatremia. This has been something that was researched a lot about a decade ago, and there's been some positive studies that have come out of this drug as well. I've included it just because some hospital formularies do already have this, and their nephrologists have already used this on some patients. So it is $4.41 for one 150 milligram tablet. This is normally given daily. And so now we're down to the cost of tolvaptan. It is about $440 for a 15 milligram tablet and $465 for a 30 milligram tablet. You also have to understand that this is upcharged to the patient, obviously, so they're going to be spending about $600 per tablet on this drug, and it's given once daily for anywhere between 1 to 7 days, depending on how bad their hyponatremia is. So that cost is, again, very stark difference from everything else that can be used to help correct those sodium levels. So question number 3, next transition. What is the biggest deterrent for tolvaptan to be used in hospitalized patients? As we mentioned, it is cost. There is a significant cost difference associated with this drug when compared to other regimens. So some takeaways is that Samska can be an effective drug. That's undeniable. There is a specific indication for this drug, as seen in those studies and from the package insert as noted before. Nephrologists and other physicians, pharmacists, and the healthcare professionals helping the patient need to weigh cost versus benefit. They need to understand the severity of the cost of this drug and note that before putting it on formulary and then also before administering it to a patient. Cost to the hospital and cost to the patient should be considered before it's given. So this is some food for thought. What would you do in your institution? I have a list of my references, and you can email me with any questions. Thank you so much.